Okay, good morning. Hi, I'm Dr. Surya Jamal from Emergency Department UKM. Today, I'll be talking on the topic of POCUS, the RUSH protocol, assessing your critically ill patients. Right. Okay, the objective of our talk today, hopefully by the end of this short presentation, I'll be able to discuss on the usage of ultrasound as an adjunct in resuscitation, and also to narrow and the use of ultrasound to narrow down the differential diagnosis of undifferentiated shock. So I think all of us has been using ultrasound quite frequently in our management of patient, and we know that ultrasound is actually one of the critical components during the evaluation of patients with undifferentiated shock, as well as in critical ill patient. So it allows understanding on the physiology of the critically ill patient. It helped us to identify life-threatening diagnoses and guide our resuscitation and procedures to help our sickest patient. For example, in a patient with cardiac tamponade. Multiple studies have demonstrated that ultrasound can aid in narrowing the differential and identifying the type of shock compared to the traditional evaluation. So when you have a patient who comes into your resus who's very, very ill, they may present with hypotension, pale, tachycardic, poor pulse volume, cold peripheries, So it's a bit difficult at that point of time for us to actually differentiate what type of shock they actually have. 50% of the time, we wouldn't know what is the diagnosis on the initial assessment of the patient. This patient may have hypovolemic shock, cardiogenic shock, distributive shock, and obstructive shock. Having said that, in some of our patients, they may also have more than one diagnosis, and that further challenge our assessment and management of the patient. So in order to assist clinician in early diagnosis and hence provide early management of the patient, several protocols have been developed to help guide the use of ultrasound in patient who presents with undifferentiated shock. A recent study has shown adding POCUS to the clinical assessment increases the diagnostic accuracy for etiology of shock from 50% to 90%. So this is a study that was recently, not really recently, it was published in 2004, quite some time ago, but it's actually quite a good study. It's a randomized controlled trial of immediate versus delayed goal-directed ultrasound to identify the cause of non-traumatic hypotension in emergency department patients. So what the study actually does is that it divided the patients into two categories or two groups, group 1 and group 2. The group 1 patient will have an ultrasound early on in the management of that patient, and group 2 patient will only have ultrasound 15 minutes after assessment or initial intervention of the patient. So what the study found actually that physicians in the study indicated that correct final diagnosis as most likely among their viable diagnosis list at 15 minutes in 80% of group 1 of subject, and versus 50% in group 2. So there's a difference of about 30% between group 1 and group 2. So basically, group 1 patient will have earlier diagnosis compared to group 2 patients. Multiple approaches to POCUS evaluation of the patient with undifferentiated shock has been described in the literature. Despite some variability between one algorithm to another, most algorithms actually focus on multiple organs and body areas to classify the type of shock and guide further resuscitation and intervention. There are two common algorithms that being used: ACEs, abdominal and cardiac evaluation in shock, as well as RUSH, rapid ultrasound for shock and hypotension. So this is an example of multiple algorithm that has been produced worldwide. So as you can see, RUSH was produced initially in 2008, and it was updated in 2010. 2010. ACEs was actually produced in 2009. So among all, RUSH is one of the algorithm that is actually quite comprehensive in diagnosing multiple diagnoses in patient with undifferentiated shock. Okay, this is the difference between the RUSH HYMAP that was initially developed in 2008 and was later developed or updated in 2010. So the initial one is HYMAP and the later one is actually RUSH pump, tank, and pipes. So the HYMAP RUSH protocol look at 5 organs systems, which is the heart, IVC, abdomen, aorta, and lungs. Whereas the RUSH pump, tank, and pipes are actually looking at 3 major components: the pump, which is the heart, the tank, which is your IVC, Morrison's, and also lung, and the pipes, which is the aorta and DVT. Sorry, aorta and also deep veins. So for this purpose of presentation, I'll only be looking at RUSH protocol, the pump, tank, and pipes. So so let's just go through on the RUSH protocol. So the evaluation of the pump, which is actually the evaluation of the heart, use 3 views. Which is the long axis parasternal view, the subxiphoid view, and also the short axis parasternal view, as well as the apical 4-chamber view. So the long axis parasternal view is looking at the heart in a longitudinal cut, and it will, in this view, you'll be able to view the left atrium, left ventricle, LVOT, and also the right ventricle. In the short axis parasternal view, you'll be able to view the left ventricle in a transverse or horizontal view, and the view that you will be wanted to try to achieve for accuracy of diagnosis is actually the papillary muscles view, okay, as seen on that picture. Right. So the third one is actually the apical 4-chamber view. So in the apical 4-chamber view, you would like to see the heart sort of cut at the apex, and then you'll be able to see all the 4 chambers of the heart: the left atrium, the left ventricle, the right atrium, and the right ventricle. And the subxiphoid view is at the subcostal of the chest. And at this view, the liver is actually the window, and you'll be able to see right atrium, right ventricle, left ventricle, and left atrium. So let's look at what can you assess from all these 4 views on the evaluation of the pump. So as you can see, the first step of assessment of the pump is actually to see whether there's any pericardial effusion. So this is again the long axis view of the heart. So you can see this is the presence of the left atrium, the left ventricle, LVOT, and right ventricle. So this is the pericardium, and you can see there is evidence of pericardial effusion. Below the pericardium or below the aorta is actually another anechoic area. In this patient, it was a pleural effusion that may mimic pericardial effusion. Right. So this is also another view to see whether there's any pericardial effusion, which is in the subxiphoid view. So in this view, you can see this is a still image, but later I'll show you a video that's the liver, right atrium. You cannot see the right ventricle from here because it has been collapsed due to the pericardial effusion. Left atrium as well as left ventricle. There's still a bit more of pericardial effusion here. So if the patient presents with hypotension with pericardial effusion, then it helps in your diagnosis of cardiac tamponade, and the patient needs to have the pericardial effusion drained as fast as possible. So further assessment of the pump showed that we're looking at the LV contractility again. So this, as you can see on the first image, this is the long axis parasternal view, looking at the function of the left ventricle. So compare the diastole and the systole. So you can see there's a difference in the left ventricle cavity. The wall of the left ventricle is actually touching each other during the systole, suggesting of a good contractility. This is further represented if you look at the M mode of the long axis view and measure the fractional shortening. The fractional shortening is actually 62%. As comparison to the image below, there's no difference in the LV contractility between diastole and systole. Even during the systole, the wall of the LV is actually not coming together, suggesting of poor LV contractility. And on the M mode, the fractional shortening is actually 27%. So this suggests that on the assessment of the palm with poor LV contractility, that could also lead to cardiogenic shock. This is a video showing the assessment of the palm in the sub-xiphoid view. So you can see that's the liver. And that's the left ventricle, and that's the left right ventricle, left atrium and right atrium. So you can see the contractility of the heart is very hyperkinetic, and as if there's no difference between diastole and systole. This is another one that's showing the long axis parasternal view. So you can see here, that's the left atrium, left ventricle, LVOT, and right ventricle. So there's a bit of pericardial effusion here. So, and that's the descending aorta. So you can see that the contractility of the heart is actually quite bad here, okay? Very poor. Again, this is another picture on long axis parasternal view. Also shows poor contractility of the heart. So in this sort of patients where you have poor contractility of the heart, then you probably would say that the most likely diagnosis could be cardiogenic infection, cardiogenic shock, precipitated by myocardial infarction and or ischemia. The assessment of the palm on looking at the RV strain pattern. So normally, right ventricle or right side of the heart is actually a low pressure area compared to the left ventricle. So the right ventricle usually will have smaller size compared to the left ventricle. However, when you have RV strain due to pulmonary embolism, for example, as you can see in this video, the RV is actually looks like the same size as the LV. Okay, and in this video you can actually see there's hypokinesia of the apical wall, suggesting of a McConnell sign. Again, on the both of these image or videos, you can see that this is the short axis view of the left ventricle, and it shows the bowing of the right ventricle and a D shape of the right ventricle as well. However, we have to also be careful in assessing these abnormalities. In patients with chronic pulmonary hypertension, they can also present with RV dilatation and RV hypertrophy. So the difference between chronic and acute is that in acute condition, there is RV dilatation, but there is no evidence of RV hypertrophy as seen on this first video. As compared to in chronic pulmonary hypertension, you will have RV dilatation as well as RV hypertrophy. So next we go to the assessment of the tank. So assessment of the tank, we're actually looking at the intravascular volume status, the effectiveness of it. So you wanted to review whether there is any fullness of the tank, looking at the IVC, whether there's any leakiness of the tank by doing fast, and also looking at the lung ultrasound, and whether there's any tank compromise in tension pneumothorax. So this is the view of the tank. So on looking at the IVC, so first of all, you wanted to view whether there is any collapsing of the IVC. So collapse of the IVC or kissing of the IVC suggests that the patient may be fluid responsive. So what you do is actually you assess the patient before giving the fluid and look and see whether there's any kissing of the IVC, and review again following the fluid resuscitation and see whether that's actually improved. Apart from that, you can also review the IVC to see whether the IVC is actually plethoric, suggesting of whether there's any obstruction, or like, for example, in tension pneumothorax, or even in acute pulmonary embolism, or whether there is, or even in decompensated heart failure, for example, there's also be plethoric IVC. Okay, this video, on the first one, it shows a plethoric IVC. So you can see there's very minimal variability of the IVC. That's the the right atrium, and that's the IVC. And compared to this one, that actually shows a kissing IVC. Yeah, kissing IVC. So you can see the IVC is very small and it's actually kissed and collapsible. So assessment of the tank, again, the second part is actually to look at whether there's any leakiness of the tank. So this is viewing and see whether there's any fluid in the abdomen by performing FAST. So the area that you wanted to look for any free fluid is the most gravitational area, which is the Morrison's area. And also looking at the lungs and see whether there's any interstitial edema or interstitial fluid by the presence of B lines on the lung ultrasound. And last but not least is actually to see whether there's any compromisation of the tank due to obstructive physiology, such as tension pneumothorax. So this is an example of the lung ultrasound of a normal lung. So you can see that the view that we are interested in is M mode at the pleural line, and to see whether there's any sliding sign and presence of seashore on M mode. As opposed to if the patient has a pneumothorax, there will be no sliding sign, and also there will be no, and the M mode, at the M mode view, it will be a barcode sign or stratosphere sign. So this shows a stratosphere sign, okay, in a patient. So you can see that's the pleural line, and there's very minimal movement of the pleural between the visceral and parietal pleural, as evidence as there is no sliding sign present. And in the M mode, it's actually a barcode sign. Again, this is also showing the same thing. So that's the pleural line. So you cannot see any sliding sign present there. No glistering effect of the pleural line, suggesting of a pneumothorax. Okay, so we go to the last one, which is assessment of the pipes. So in assessment of the pipes, we are actually looking at assessment of the arterial and also venous system. And so in the arterial, we're looking at whether there's any rupture of the pipes, such as in abdominal aortic aneurysm or dissection. And in the venous system is actually to see whether there's any deep venous thrombosis on the femoral and the popliteal veins. Yeah. So the view that we will do is actually all the aortic view, and as well as the 2-point compression test of the lower limbs venous lower limbs veins. Yeah. Okay. So this shows, you can see, okay, this is an abdominal ultrasound on the abdominal aorta, and you can see that there's enlarged abdominal aorta with the presence of thrombus inside the abdominal aorta, measuring about 8 times 8 centimeter. Okay, on further assessment of the abdomen on the video itself, so you can see that's the abdomen, and yes, increase in the diameter of the abdomen, okay, more than 5 centimeter, and you can see there's presence of thrombus, yeah, inside of the abdomen, or even probably there's actually dissecting aortic aneurysm, as there is a false and a true lumen. Okay, again, on this one, these videos, you can see there's a dissecting aortic aneurysm, as there is a flap. You can see there's a flap, presence of flap, yeah. Presence of flap in the abdominal aorta. That is your descending or your abdominal aorta. How about your thoracic or your aortic root? Aortic root, if it's more than, so the view that you're looking at is the long axis parasternal view at the LVOT. If the LVOT or the aortic root is more than 3.8 centimeter, and there's presence of intimal flap, then it suggests that there's dissecting thoracic aortic aneurysm. Okay, last but not least is assessment of the pipes to look at whether there's any deep vein thrombosis. So the view that we're doing is 2-point compression view, which is at the femoral vein and at the popliteal vein. So this is an image that shows presence of thrombus in the femoral vein and clots. Again, this is a video. So in this video, you can see that the femoral vein is actually non-compressible, and there is presence of clot in the femoral vein itself, suggesting of deep venous thrombosis. So how do we put it all together on the pump, tank, and pipes? So hopefully when you actually do the RUSH protocol, you're able to differentiate between hypovolemic, cardiogenic, obstructive, and distributive shock. In this table, as you can see, if you have a patient with hypercontractile heart and small heart size, then as well as with kissing IVC, may have peritoneal fluid or pleural fluid if they are losing fluid. For example, if they have AAAs, yeah, and they have perforated viscous, so they have loss of fluid. So that suggests presence of free fluid in the tank. And also on assessment of the aorta, there is also aortic AAA, aortic abdominal aortic aneurysm, and also or even aortic dissection, suggestive of a hypovolemic shock. In a cardiogenic shock, assessment of the pump will show a hypocontractile heart with reduced ejection fraction, dilated heart size. You may have a dilated IVC, dilated IVC, and presence of B lines, pleural effusion, and ascites. In obstructive shock, such as in PE, and even tension pneumothorax, you may have a pericardial effusion, RV strain pattern, hypercontractile heart with distended IVC, and absence of lung side sliding in pneumothorax. And on assessment of the pipes, you will find thrombus formation in the femoral or popliteal vein. in distributive shock, for example, in sepsis, you can have either the assessment of the pump, you can have a hypercontractile heart or even a hypocontractile heart due to myocardial depression on the late syndrome of sepsis. You may have kissing of IVC if it's a mix between, distributive and hypovolemic shock, or you may even have a normal IVC. You may find on assessment of the tank pneumonia suggestive as the cause for the sepsis, or empyema, or even free fluid in the peritoneum that's standard on assessment of the examination suggestive of peritonitis. Okay, let's look at this. So this is the apical four-chamber view. So you can see from this video, the heart has very poor contractility. The IVC is actually distended. The lung shows multiple B lines, okay? And this may suggest a cardiogenic shock, probably secondary to myocardial infection with heart failure. Okay, again, on the same sort of presentation, right? So you can see this is the long axis parasternal view, very poor contractility of the heart. The LV is barely contracting. This is the short axis parasternal view. Again, very poor contractility, and you can see there's some wall of hypokinesia of the short axis parasternal. IVC is distended. Presence of free fluid in the Morrison's area as well. Okay. Obstructive shock, all right? So you may see whereby that you have quite a normal or hyperdynamic heart. Yeah, the heart is contracting hyperdynamic, but or in certain areas it's actually normal. IVC is actually distended, yeah. And on the assessment of the lungs, there is absent lung sliding, and also presence of barcode sign on M mode of the lung, suggestive of pneumothorax. In again, this shows the heart in the I think this is a subxiphoid view, presence of pericardial effusion. Yeah, very big effusion with compressing on the RV. Yeah, compressing on the RV. Again, swinging heart. Yeah, very big pericardial effusion. Yeah. Again, this is the apical four-chamber view. You will see very big pericardial effusion with very small RV because it has been compressed by the pericardial effusion. IVC is also distended, okay, because of increase in intrathoracic pressure. So this suggests cardiac tamponade in the presence of hypotension. Right. So this is another one of obstructive shock with the diagnosis of pulmonary embolism. You can see there's very large RV and also RA, almost it's equivalent to the same size as the left sided of the heart. There's probably hypokinesia of the apical wall as well, probably suggestive of McConnell sign. Okay, very dilated RV, yeah, and causing bowing of the septum of the LV, distended IVC, and presence of thrombus in the peripheral veins. So suggestive of DVT. So this goes to or sum up to the diagnosis of possible pulmonary embolism. In hypovolemic shock, okay, you may have a very hyperdynamic heart. So you can see the heart is actually contracting very fast and hyperkinetic. The LV is the wall is actually kissing with each other, right? And again, this is the short axis parasternal view. So you can see the very hyperkinetic heart. Kissing IVC, yeah, kissing IVC, suggestive of low volume. and as well as it may shows presence of free fluid in the fast, suggestive of whether there's any the hypovolemic shock is secondary to probably perforated gastric ulcer, ruptured ectopic pregnancy, or ruptured appendix, yeah, or even trauma. Okay, so this is just to show a ruptured ectopic. So you can see this presence of free fluid, yeah, and presence of some POC, yeah, at the ectopic area, not in the uterus. Okay, this is also another videos showing possibility of ruptured AAA as the cause of hypovolemic shock. Again, the same thing. You can see a very hyperdynamic or hyperkinetic heart, kissing IVC, and there's presence of abdominal aortic aneurysm on the assessment of the abdomen, suggestive that this is a hypovolemic shock secondary to ruptured abdominal aortic aneurysm. Okay, again, another video that shows abdominal aortic aneurysm. So you can see there's presence of possible even dissecting because there's false and true lumen. Okay, distributive shock. This is probably a bit difficult to diagnose, whereby you can see that your on the short axis parasternal view, the heart may have either a small end systolic volume or a large end diastolic volume. Okay, slightly hyperkinetic. So in this one, in this short axis parasternal view, this may show there's a large end diastolic volume and small end systolic volume. IVC is kissing. Okay. Presence of other causes that actually precipitates or predispose the patient to sepsis, pneumonia. Okay, so you can see there's shred signs, yeah, on the lungs. Vegetation, infective endocarditis, presence of some vegetation of the mitral valve. Okay, gallstones, yeah, that may cause gallbladder empyema, but presence of gallstones that causing cholecystitis maybe, or gallbladder empyema that lead to sepsis. Okay, so you can see some sediment in the gallbladder, yeah, in gallbladder empyema. Some collections, yeah, abscess that predispose also the patient to sepsis, and appendicitis, yeah, that suggestive of either if you have free fluid, then it suggests a ruptured appendicitis. So all this predispose the patient to have septic shock or distributive shock. So again, this is the summary of what I've shown on all the pictures. So what is actually the evidence on using POCUS in assessment of shock? Is it actually, does POCUS actually helps in your management, or does it actually change the patient outcome? So one of the study that was recently published in 2021 shows that the adult patient admitted to internal medicine ward with cardiopulmonary diagnosis who underwent multi-organ focused clinical ultrasound of the heart, lungs, and lower extremities vein during their initial clinical assessment did not have a shorter hospital length of stay by more than 24 hours compared to patient who received standard care. Another study published in 2018 shows that comparing POCUS to standard care without POCUS in undifferentiated emergency department patient who presented with hypotension, there is no benefits in terms of survival, length of hospital stay, rate of CT scan, inotropic use, or fluid administration. So the addition of POCUS protocol to standard care may not translate into the survival benefit of the patients. However, it does help in assessment in your assessment or to get early diagnosis, and hence continue management of the patient and also monitor the management of the patient using POCUS itself. I think with that, thank you.